Thank you, Yi Chen, for the exotic Latin moves.
感谢玉成带来的精彩绝伦的拉丁舞步。
As our last speaker today, we have Associate Prof Chng Wee Joo, a senior consultant at NUHS, to give us some medical insights on what is autologous stem cell transplant and how it may benefit you, and it has benefited Mr. McCarley.
接下来我们有请今天的最后一位演讲者庄伟玉副教授，他也是国立大学医院的资深顾问医生。他今天将向我们介绍有关自体干细胞移植的相关知识，以及这个疗法如何帮助到在座的各位病人，正如麦卡利先生所得到的帮助一样。
Good afternoon. So, good afternoon. I have a very difficult task. This is the post-lunch session, last talk. I'm even amazed that you guys are still here, so thanks very much for staying. Okay, so before I go into this talk, I need to say some thanks as well. And again, I want to thank Liu Xing for actually, once again, putting on the show today. Many of the volunteers, the performers, were some, people that she sourced from the internet. So she really has, done the whole program much on her own and with some support from SGH Nursing as well as our other colleagues. So I want to thank her for again putting on such a good show for our patients. I also want to thank the volunteers. We have more volunteers earlier. Maybe I should have said this earlier, but we have many of the volunteers that have come from my own research lab as well. I don't know whether you all who have been here for all these years will recognize Chong Wee. He has been documenting our progress over the years as our photographer for 4 or 5 years now, and he's actually working in the lab on better ways to understand myeloma and treat myeloma. So I think this also relates to what Leonard mentioned earlier, that he hoped to raise more funds for research in myeloma. Because we feel that actually if we stay where we are now and we are happy with what we have now, there's no way that we can even try to cure myeloma or get better treatment for myeloma in the future. So I think research is very important, and we do it in a few ways. One is to bring clinical trials so that our patients can get access to new drugs, to effective drugs. And in fact, looking down at the audience, we have a number of patients here who are actually currently on clinical trials and in fact probably benefiting from those trials. The other thing is the research that we do in the lab, where we try to understand the disease better, find better ways to treat and kill these myeloma cells. And many of the volunteers actually here are participating in that activity. So I find that particularly meaningful. Those people working in the lab, they come here, they see the patients, and they see who are the people that they try to help in their work. And then second of all is I want to also say that the patients have done a lot for this group. It's not just through coming for the meeting and so on, but I think most of you today would have gotten a booklet that we have produced, and many of those questions and informations were actually things that the patients ask when they are diagnosed or when they're told that they need certain treatment. So they come in the format of a series of questions that patient commonly asks, and we actually have some patient who volunteered to vet through the information to make sure that it is generally understandable by laymen. So again, I'm very gratified by the fact that the patient actually took time to help us in this kind of meaningful project that eventually goes back to help patient. So why I choose today's topic is, again, just now during lunchtime, I was approached by a few patients, and almost invariably every one of them was asking me about transplant. I don't know whether because on the program it says I'm going to talk about transplant, but clearly transplant is something that worries a lot of patients, because when we think of transplant, we think of things like kidney transplant, heart transplant. All these are big operations, and patients need to take drugs for the rest of their life and all these things. And when we talk to patients who have undergone these procedures, we also hear some horror stories. So we get very scared, and we think that it's something really very dangerous. But so what I'm trying to do today, hopefully, is to really debunk some of these myths. A lot of these are misunderstanding, probably wrong information from wrong contexts, misinterpretation of messages. And hopefully, with my talk as well as Leonard's sharing of his experience, we will try to lay some of these ghosts to rest in that sense. So when we talk about stem cell transplant, right, we really generally is talking about generally two types of stem cell transplant. It all depends on where the stem cells is coming from, okay? So if you are using your own stem cells, there's no point. If you are using your own stem cells, then it's called autologous transplant. If you are using other people's stem cells, then it's called allogeneic transplant. And where does this other people's stem cells come from? They could come from a sibling, meaning your brothers and sisters, who are completely matching with you in terms of their protein profile on white cells, or they can be coming from a parent or a sibling that only matches half. So a parent, because your genes come from your father and your mother, if your mother would necessarily only have half the composition of your gene, and your father the other half. So that makes almost everyone having a potential donor in having one of the parents if this kind of transplant is possible. Unrelated, that means from someone who donate their bone marrow to a registry, okay, and we check and match them to see whether they match you. And then also from cord blood. So this is where all the KK and Thompson Medical Center, when you go to give birth, they'll ask you whether you want to donate to the cord blood bank. And so we certainly can use cord blood for transplant as well. I'm not going to talk about this, although we occasionally, very rarely do this kind of transplant in myeloma. This is really not the kind of transplant that most of you will be having and will be worried about. Okay. So we're talking about autologous transplant where you use your own stem cells. So why do we need to do this kind of transplant for myeloma patient? And the reason is the transplant prolong the survival of patient with myeloma. So these are a couple of survival curves. You can see very easily that with transplant, this curve is going up towards the right-hand side. Okay, this means that patients are surviving longer than those who didn't have transplant. So clearly, it benefits the patients. And these are other studies that again shows that across the board, things like progression-free survival, when would the disease relapse, how long the patient's going to live, all seems to predominantly favor the transplant group. So if you do transplant, you have a longer period of time without the disease or with the disease in remission, longer time before your disease come back, and you survive longer. So what is there not to like about transplant? Okay. But now we have very effective treatment, right? We have all these Velcade novel agents, they seem to be very easy to take. I just go to clinic, I have an injection, I even sometimes take pills at home. These are very simple kind of treatment, and usually patients tolerate it quite well. So in the context of that, when I have simple treatment that I can take at home, just come to clinic, do I still need to have this transplant? Particularly if I'm already scared of the transplant? Now, the answer is that probably still yes, until we have better evidence to tell us no, right? And the reason why I say that is that many of these studies using Velcade, dexamethasone, Velcade, adriamycin and dexamethasone, Velcade, thalidomide and dexamethasone, which is common things that we use in the clinic nowadays. When you have the transplant, you still get a much better response rate after the transplant, almost across the board for the different studies. So meaning to say that the transplant still adds to the treatment that you have, even with novel agents. And more importantly, people have started to look at, okay, since there is doubt here and these new agents are so good nowadays, right? Why don't we compare them directly? So this is such a trial that's being conducted in Europe where they treat the patients with just novel agents containing treatment like Revlimid Dex followed by Melphalan, Prednisolone and Revlimid versus after 4 cycles of Revlimid Dex they go on to have a transplant. Then after that, no maintenance. So we don't look at this, we just want to see this comparison. Now if we suspect that with the way that we treat patients now, we don't need a transplant, then we will expect these patients to do as well as these guys or even better. But that's not the case. You can see that the 2-year progression-free survival is still much, much better for those that have the transplant, and this is statistically significant. Okay? Meaning that to say that even this latest study where they directly want to make a comparison between no transplant and transplant, using the novel agents, it still shows that the transplant probably benefit the patient. So at the current time, I would recommend transplant for all patients with myeloma who is fit enough to have a transplant to undergo that procedure, because it benefits the patient in terms of living longer. Okay, so how does the transplant work then? I mean, we keep talking about transplant, so how does it work, and why is it effective? Why does it prolong patient survival? Now, the trick in the transplant here is not the stem cells. What is killing the cancer cells and what is effective in killing the cancer cells is the chemotherapy that we give before the transplant. And that is the melphalan. Okay? It is a very effective treatment for myeloma. So the story goes like that, right? I mean, this is a real story, it's not a fictional kind of story. In the old days, it's very hard to treat myeloma. We have very, very few good treatment for myeloma. It's only steroids and melphalan, right? And so people find that if you give higher and higher and higher and higher doses of melphalan, the patients get better and better and better and better response. Okay, to the point that if you give them high dose type level melphalan, you can actually get rid of all their myeloma, go into complete remission, no more detectable MBAN, no more plasma cells in the bone marrow, which is what we want to achieve, try to get rid of the tumor. But they have a problem. These patients die within 100 days of having the high dose melphalan because their bone marrow function never recover. So they permanently have very low white cell count, very low hemoglobin, very low platelet count. So these patients die of severe infection or bleeding problem and so on. So this is where we know that we have an effective treatment, but we cannot give it to patient because we kill the patient at the same time. And that is where the stem cells come in. So when we give the patients their healthy stem cells back, these stem cells are the kind of cells that produces all the blood cells that we have in the body, including those cells that we need to fight infections, such as your B cells, your T cells, and your plasma cells, and your blood-producing cells, and including platelets and so on. Okay? So actually the stem cell transplantation, the stem cells that we give back to the patient, is not doing anything for the cancer cells. It is to save the patient. It is so that the patient's bone marrow function can recover, they can start to produce the blood cells, they can start to have their immunity go back to normal and become healthy so that they don't succumb to infection. Okay, so that is why we do transplant, and that's how the transplant actually works. Okay, so when does a patient usually go into this transplant? So usually what we want to do is to give them some cycles of induction treatment, the treatment at the beginning. Okay, so many of you would have like VCD or VTD, for induction. And we need to give this induction because we want to rapidly reduce the tumor burden, rapidly kill off as many of the cancer cells as possible, and reduce the M protein level. So you see this nice reduction in M protein. And when we reach 50% reduction in M protein, that's called a partial response. Okay, and if we are able to achieve that after 4 cycles of the induction, then the patient is fit to go into a stem cell transplant. So, in the previous speaker's slide, they showed that, after 3 or 4 cycles go into transplant. That's the reason, because after 3 or 4 cycles, most of the patient would have achieved at least a partial response, to this new treatment. If you haven't quite reached there yet, then we may give 2 more cycles up to 6 to get you into a partial response. If you don't get a partial response by that time, then it suggests that the treatment is not really working, and we may need to change the induction treatment to something else that is effective before we bring the patients to transplant. Why don't we do the transplant straight away? And that's because the transplant being a single treatment, one-time point, is not enough to eradicate all the tumor cells that you have all at the same time. And studies have shown that if you go into transplant before achieving at least a partial response, 50% reduction in the tumor cells, you are not going to be successful. Okay, so that's why we give them initial cycles of treatment to rapidly reduce these bad cells. Okay, so Then how do we do this transplant? So now I'm going to go into a bit detail about the procedure and what you expect when you undergo this transplant. So there is 2 steps. Okay, I always tell the patient there's 2 steps. Step 1 is where we collect your stem cells. Okay, or we call it stem cells harvest. Step 2 is where we give the chemotherapy. This is the high dose melphalan, followed by the stem cell infusion. Okay, and in Europe and US, sometimes they call it stem cell rescue. That's because precisely the stem cell is there to rescue the patient. Okay, again, reiterating that the stem cells function to repopulate the bone marrow function and not to kill the tumor cells. So what do we do during the stem cell harvesting part? We first need to mobilize the stem cells. Okay, the reason is these stem cells, they live inside the bone marrow and they are very sticky to the bone. Okay, so they're normally stuck to the bone, and that's why in the old days we have to do bone marrow harvest. So the patient actually, most of the patient here would have undergone a bone marrow test where we stick a needle into your pelvic bone and we take out some blood there to check for plasma cells. So in the old days they have to do this repeatedly and suck out the bags of blood to get the stem cells, because the stem cells live inside the bone marrow. But nowadays what we can do is that we can give patients medication to mobilize these stem cells so that they no longer are sticky to the bone and they can float in the blood and start to swim out into the blood. Okay? So we usually give them GCSF, which is an injection that both lead to the increased production of these stem cells as well as to make them less sticky. And in NUH and I think SGH as well, we also give patients 2 other medications, cyclophosphamide and vinorelbine. Again, these drugs in very high doses are actually chemotherapy-like drugs, but in the doses that we use, more function to mobilize the cells. Okay, so some patients do have some hair loss problems, some nausea, but usually quite mild. Okay, so they will help to mobilize these stem cells and increase the production of the stem cells. Okay, so now these cells are swimming around in the blood and more is being produced. Then we can collect the stem cells from the blood. So no longer do you need to go to the theatre. Last time the bone marrow harvesting is an operation. You need to go under GA, need to be on table, and the 2 hematologists will be collecting stem cells from both sides of the buttock. When you wake up, it's very painful. You can't walk for a good few days. You need a lot of morphine to control the pain. Now, no such thing. Now it's simple. Now it's like going for blood donation. Okay, we basically use machines like this, which has a circuit, with tubings going in and out, and the patient sit on the chair or lie down in the bed, and they get connected to this. And this is what Leonard was saying. You go into here and then the blood get returned. Sometimes we use a big vein in the arm. Sometimes we use a big vein in the groin area, in your upper thigh. Depending on patients, whether they have strong and big veins, and where they are located. Like I said, he sit down there for 4 hours, and basically it is this blood going out into this circuit, and then going back, and then we'll collect the stem cells and then return the rest of the blood to you. Okay? Actually, Leonard shouldn't have been too disappointed because maybe it wasn't convenient. Most of the time, patients need 2 or 3 days. Okay, 1 day is a bit unusual, but can happen. But usually 2 or 3 days. And the reason is because we need to make sure we collect enough stem cells so that when we do the procedure, it will lead to a fast and a recovery for the patient, and it will be safe for the patient. So minimally for each transplant, we'll need about 3 million stem cells. Okay, but if we want to do transplant safer, right? The higher is better. So if we have 5 million, it will be good, very good. And in myeloma, because the nature of the disease is that the disease may relapse, may come back, and if it comes back, you may actually then benefit from a second transplant. So we collect enough stem cells for 2 transplants. And also some patients, after the first transplant, their response may not be very, very good. They may also benefit from a second transplant about 6 months later. So we collect enough stem cells for 2 transplants. So altogether, we would like to usually hit the target of 10 million cells before we stop. Okay? So that's again the reason why we need sometimes 2 days, and the question of why is it not enough. So what do we do with the collected stem cells? It actually is in a bag of liquid, right? So we freeze it away. Okay, put it in the liquid nitrogen together with a preservative called DMSO, and the DMSO is what gave Leonard that funny taste, you know. It's a funny kind of, I don't know, fruity corn taste. Yes, like sweet. I don't even know that sweet corn is probably just lousy corn actually. It may make you feel a bit nauseated, you know, the kind of feeling, but it is in the room, and you know, you basically, when you breathe out, it's in there. But after a few days it will go away, but basically that's what it is. It is what we use to preserve the cells and freeze them down. So similarly, when it's time for transplant, we will take this out from the liquid nitrogen, and that's why there will be a technician there that need to thaw it down, okay, because it needs to not be frozen or else we can't give it to you. So you need to be put in a water bath in a graduated, you know, controlled fashion so that the temperature slowly thaw out the cells for use. Okay, so that's the harvesting, and then, you know, how we freeze it away. So when it comes to the part 2, this is what happens. So just a bit more about part 1, right? What are the side effects? You know, some people may ask. You know, so when you have the mobilization, the 2 drugs that we give, some patients get a bit of nausea, some patients may start to lose some hair, but those are, to me, you know, not very significant, usually controllable and manageable. When we give patients the GCSF, the jab, to increase the production of these white cells, again, usually not much of an issue. The injection is into the skin. It's like diabetic patient having insulin injection, so not a big needle, not a very deep injection. But when the marrow get very active, you know, when it's about time to do the harvesting, the patients may get bone aches because the bone marrow is working and is expanding. So some patients, the ache is very painful and they may have to take some painkillers, you know. But that usually, when you tell patients and they expect it, usually again not a problem. It's only when patients don't expect it, it's like, wow, suddenly I'm so painful, you know, then they are afraid that something is wrong. And then when they are undergoing the harvesting, because of the circuit, we need to put in anticoagulant in the circuit so that the blood doesn't clot when they flow into the tubing. Some of these anticoagulants actually absorb calcium from your blood. So sometimes at the end of the collection, the patient may have low calcium or low salt content, causing some numbness around the mouth and so on. But again, that's manageable because as a routine, we check patients' blood every evening after the collection, and if they need, we'll give them replacement calcium, replacement potassium and so on. So usually, again, not a big issue. They may also lose some blood in the circuit, so some patients may have anemia, may have low platelets, and again we'll check, and if it is significant enough, we will give them transfusion. So all these things are very routine, well rehearsed. We know what to expect, we know what to happen, and so usually very manageable. So that's part 1. So after part 1, we usually let patients have a bit of a 2 weeks break at home and rest, and then we'll see them in clinic, make sure they've recovered well from the procedure before we embark on part 2, okay? So part 1, they stay in hospital for about 2 to 3 days during the mobilization, and then another 2 or 3 days during the harvesting. For the stem cell transplant, they stay in hospital for about 2.5 to 3 weeks, okay? And this is what they get. So the first day they come, they get a line that is inserted into the jugular, like what Leonard said. This is done in the X-ray department, very safe, very experienced people doing it. You get this discomfort of something sticking out from your neck, but this is what we use to give all the drugs and what we use to take blood. So after the 1 procedure, you should have very little discomfort in the sense that everyone have to kind of poke you every day, you know, to find veins, to put drugs and so on. Then after that, we start the Melphalan, 2 days. Then you get a rest day, then the stem cell infusion, which is what we call the new birthday for the patient. Okay? And this is what we do. Basically, this is the bag of stem cells. So after thawing, you know, after thawing it out, this is the bag of liquid stem cells that we give through a pump into the patients, through the line that they have. Okay, and as you can see, this guy is pretty happy. So what would I expect? So those are the procedure. What do patients normally expect? So I've gone through some of these bone pain. During line insertion, you may get some slight discomfort, bruising on the skin sometimes, or get there and so on. During the chemotherapy, you may get this, I've already mentioned. So for the melphalan, the high-dose melphalan, right, it has, of course, more side effects than other kind of treatment that you have. So don't kid ourselves like this is going to be as simple as like taking thalidomide at home or having the Velcade, okay? So I'm being honest here, and you will get a bit more side effects than that. Okay, you will get a bit more nausea and vomiting, but we have very potent anti-sickness pill nowadays, which we give to the patient. So usually quite well controlled, okay? And if some patients still not well controlled, we have more drugs that we can give to control that. The loss of appetite and fatigue guaranteed to happen, very hard to completely prevent. The only thing that I'll tell patients is that it's only temporary, okay? Because the transplant procedure, from the time when we give you the stem cell infusion to the time that you recover is only in the order of about 10 days to 2 weeks, and the problem usually start to come in, during that 10 days, So it is not a matter of months that I have to tolerate this. It's usually a fairly short period of time. So stick with it. Try to adapt yourself, different ways to improve your nutrition. Use energy drinks, break up your meals into smaller bits throughout the day, and force yourself a bit. Have the mental strength to do it, but usually not, again, a long-term problem. Mucositis and diarrhea can happen because melphalan does affect the lining of your mouth and your gut and all those things. So we get patients to suck on ice before we give the melphalan to prevent this mucositis. In general, that has worked very well, and we have seen much less of these severe mucositis problem in patients undergoing this. In the old days, patients, some of them get very bad ulcers in the mouth to the point that it's very hard to take food. But nowadays, very rare to see that. Most patients, again, have no issue. The amount of stem cells we give patients also matters. If we give more stem cells, you get less of these problems and you recover faster as well. And that's why the stem cell dose is very important as well. If you get diarrhea, we can also control that. And then, guaranteed to happen, the blood count will fall. About a week after the stem cell infusion is about the time when your counts will be the lowest. Then it will start to come back up again. So when the count is low, you have infection problems, you have need for transfusion. But again, when you're in the hospital, we'll monitor this, and usually this thing will be picked up very fast. The nurse will come and check your temperature every 6 hours. Once you have a fever, even when you don't feel anything, they will alert the doctors, will check whether it's infection or not. So it's usually very, very thoroughly checked. During the infusion of the stem cells, some patients have allergic reaction, because you can imagine the stem cell is like blood transfusion. Some people, when they get blood transfusion, they get a bit of allergic reaction, skin rash, a bit of breathlessness. Some people just a bit of fever. So different degree of problem. But again, we usually give patients Panadol and some anti-allergic treatment before the infusion, and that is usually prevented. Sometimes, because of all the bags of water that they may get very bloated and retain fluids. But again, we have very careful monitoring of this, and if patients have excess of fluid in versus out, we'll give them something to get rid of the excess fluid. So usually, very, very controlled environment. So that's the transplant, and from the sound of it, really, after I explained to you, hopefully there's a better understanding and what it entails, and it doesn't really sound that scary anymore. Whether we need more treatment after transplants, it really depends on a large number of factors. Whether you have very good response after the transplant, what is your risk, when your disease was diagnosed, do you have high-risk disease, low-risk disease? The best evidence for maintenance at the moment appears to be Revlimid, but even that evidence to me is not 100% very clear. There are slightly conflicting information, and also the follow-up of some of these patients are not long enough. So my advice to patient is this, because there are so many factors we need to consider. One is the cost of the treatment. Number two is the potential side effects of the treatment. Number three is the fact that the patients still have to take treatment. Some patients don't like that. They tell me that if you are telling me that the evidence is not very, very good, okay, and this drug is very expensive, I'd rather not have any more treatment, but I will come back to your clinic for follow-up. If I have relapsed, I can have treatment then. Some patients say that, well, actually, I'm quite concerned not having any treatment. I really want to have some treatment all the time because you tell me this disease will come back, and I have insurance coverage, the drug is not an issue. Then we'll go with the maintenance. So in some ways, I will have the discussion with the patients, except for those patients that have high-risk disease, then I think they should have maintenance because those patients are the ones almost certainly where the disease will come back very fast. So I will just briefly go through 4 things that patients commonly ask me about. They ask me whether transplant is very dangerous, is it very expensive, does it lead to long-term disability? After transplant I can't go back to work, I'll become an invalid, I have to stay at home, I need a carer to look after me all the time. Or whether the transplant can only be done in a hospital. I'm a bit scared of hospital. Like recently I just met a patient that wants transplant, but he's saying that, well, your transplant is done in an isolation room, it's one person. I'm scared to be alone. Then I say that, but the nurses will come in, but I'm scared to be alone at even 1 minute. I need to have someone around. So that kind of thing raises an issue that, oh dear, how to solve that kind of problem. And depending on the wards, the family members cannot stay inside the room, at all times. So we have potential problems there. So I will go through this briefly. So the treatment mortality, okay, these are hard facts. Again, there's no point kidding ourselves. About 2%, so 2 in 100 patients who undergo transplant may have a severe complication that will harm them. Okay. But this is a really low percentage. Even chemotherapy, any kind of treatment will have their own potential complication. And if you look at the chances of dying just from driving any kind of vehicle, and Leonard will know he's a pilot, but I know pilot very safe. Flying is actually very safe. Is 1 in 82 in the US. Okay, so our transplant is safer than driving anything, and we have people driving to work and everything all the time. So we need to put this into context. And also, more importantly, is the transplant is good for the disease. So when you have that benefit in mind, then again you should have less concern about whether this is something that's going to be extremely dangerous. Is it expensive? Yes, it is expensive. It's about 25,000. This is our NUH rate for subsidized patient, and more expensive for private patient. But again, you can cover this with your Medisave and Medishield inpatient. Every day there's an allowance, so usually the patients don't have to pay a lot of cash up front. But bear this in mind, if you do not have the transplant, you also cannot stop your Velcade treatment just like that. You will need more cycles of Velcade treatment. The additional cycles of Velcade treatment is also not cheap. So at the end of the day, the difference in cost is really not great. But if you have the transplant, after the 2 months of the whole transplant procedure, your treatment could be possibly finished. Right? I don't have to keep going back to the hospital for my Velcade injection. My thing is finished. And even then, when we talk about maintenance, it will be just a pill taken at home, either thalidomide or Revlimid. So it actually makes the treatment more finished faster, and again, data show that it benefits the patient as well. Long-term disability, absolutely no. We got a classic example in Leonard McCulley, after the transplant, within how long he's already cycling and going biking and so on. We have people who after transplant go back to work, and this is very important because treatment is expensive, so the fact that they can go back to a useful occupation and having continued income is also very helpful. We can't say that of all the cancer patients that we have, actually, And some patients may even look a bit younger because the hair, when it's white, the initial hair that grow back could be black, Of course the white will come back in, no escaping from the thing. For a short time you may fool people. But there are some conditions and some little inconvenience that the patient have to take note of, is that they have to take care of themselves really within the 6 months period after their transplant because their immunity is low. But I'm also not talking about some ridiculous thing, just be sensible, avoid crowds, wear masks if you have people coming to visit you that is not feeling so well. eat clean and well-cooked food, exercise and so on. And then slowly, your physician will guide you if your physical activity is good, your blood counts are good. Slowly, you can start to do a bit more and more and more. And most of the time, people after 6 months will be going back to pretty much, what they were doing before. Okay, so these are simple things, nothing too complicated. Can it be done outside the hospital? The answer is yes, because again we have an example. This is Madam whose DRT was done here in NUH. We can do transplant in the outpatient setting. Okay, the sad thing is that this currently is not so beneficial to Singaporean patients because you can claim less Medisave and Medishield with treatment done in the outpatient than as an inpatient. So because the transplant is an expensive procedure, for those who have to pay, don't have insurance coverage and so on, it means that you have to have more cash upfront or more cash payment if you have the transplant outpatient. We are currently talking to the ministry and working with them to see whether we can get this covered. And in fact, our idea is that we shouldn't look at treatment coverage, whether it's in or outpatient. We need to look at them as the treatment. So whether it's a PET scan done in outpatient or inpatient, it should be covered the same. Because what end up is the whole patient get admitted to the ward for bone marrow, for PET scan, when this can be done in the clinic. So that is something that we are negotiating with MOH on. The truth is when we do it as outpatient, it saves the patient a lot of money. It reduces the time that they spend in hospital, the days in hospital also much less. Complication, which is what people are worried about. You tell me that I need to be in a single room, then you tell me that I can do it at home, what's going on there. With proper education and selection of suitable patients, and this is not suitable for every single one, they must have good carers, good home environment, they cannot be living alone, they must be fully understand what are all the things that are required. Look at that, the infection rate, the same almost exactly, and there's nobody who die because of these transplant procedure. So, we have had a few patients who have benefited from this and they all say that this is something that is very good. Okay, so hopefully that debunked the myth. The poor immunity of the patient is not really that bad. The fact that they can have the thing at home means that they are not so severely immune compromised for such a long period of time that they are at such high risk. Okay, because the nice thing about here is that the period of time where they are weak is very short. Okay, so transplant is a good treatment. It is another available treatment which I think for a disease like myeloma, where the disease keeps coming back and we need to keep treating the patients, you want to have all your weapons available to you. You don't want to discount any weapons. Because once discounted, it may not be available to you next time, right? Because if now I don't do the transplant, if next time the disease comes back, I'm 67 or 70, no more transplant, right? So I already reduced one chance I have of getting a good treatment, right? So don't throw away a good treatment. It's relatively safe, expensive, but not necessarily more expensive than continuing treatment. And we've got good system in place through insurance, Medisave, Medishield, MSW are very used to helping patients who need transplant. So usually I don't see financial issue as something that's blocking transplant for any of our patients. Okay, subsidized or not subsidized. Okay, that's it. No questions for now.